the computer. I'm going to hand over to Abhijit. Abhijit, the floor is yours.
Thank you, Alok. Thank you so much. Guys, good morning, afternoon, and good evening from different parts of the world you're joining us. And yes, so let's start with the abnormal lung then. Right, so we're going to talk about the pneumonia and a few other pathologies in the abnormal lung. As you have guys already gone through the pneumothorax, so I'm not going to touch that, but might see some slides here and there while we do the discussion. Right, so pneumonia. And this is one of my favorite image of the graph, which talks about the air fluid ratio curve. What you can see here on your x-axis is your fluid, and on your y-axis is your air. And you can see the percentage of air and the percentage of fluid. Now, if you have 100% of air, you call that as a pneumothorax because there is no lung and it's only filled up with air. And you don't see the pleural line as well. So that's 100% air, pneumothorax. And 99% of the air with the sliding of the visceral and the parietal pleura, you see a normal lung. And as it should be for the normal lung, it's filled up with 99% of the air. It's a air-filled sac. As you keep on growing, going towards this end of the curve where you are adding up fluid, you can see the imaging changes. So you start adding the fluid, which is not normal for the lung. You start adding fluid in any form, liquid in any form, transited, exited, fibrinous strands, anything. So you start replacing the air with the fluid. So you have left with 97% of the air and 3% of fluid. That gives you the interstitial syndrome, which is basically the thickening of the septa. You start seeing B lines. Now, mind you, in one segment, up to 3 B lines is normal. But anything more than that is indicating about some pathology. You start adding more of the fluid, as in you are replacing more of air with fluid. You go to interstitial syndrome. You start getting ground glass appearance, more B lines, coalescing B lines, compact B lines in TTN, in RDS, in pneumonia. So you start getting more of B lines now. You replace 10% with the fluid, transited, exited, it might be anything, or for that matter, hemorrhage, filled up with blood. You start seeing the picture of a, compact, dense lung field, and compact B lines and, broken pleural lines. So that's what happens in pneumonia as well. You start adding more fluid, in atelectasis, complete collapse of that alveoli. That's what the definition of atelectasis is. You're just left with the 5% of air. And now, when you have pleural effusion, parapneumonic effusion, pleural effusion because of some other pathology, ascitic baby, sorry, not the ascitic, but the baby with the hydropic baby is what I mean. So baby having fluids in all the parts of the body. So it's, or can be the pleural effusion. You end up getting almost fluid around the lung, absolutely fluid around the lung, and that gives you 0% air there. It's all replaced with the fluid. And then as for the ultrasound is concerned, so fluid ultrasound loves the fluid, so it augments the propagation of the ultrasound wave. So you start seeing all different kinds of signs, which we're going to talk about in today's session. And as up over here, towards the 100% air or 99% of air, ultrasound wave doesn't like the air. So it hinders the propagation of the ultrasound waves, and you get different kind of signs over here, which you have already discussed with Alok. Moving on. So what happens in pneumonia? So lung ultrasound is superior to chest X-ray in diagnosing pneumonia. So there is no doubt about it. As you can see here, the sensitivity of the lung ultrasound is 86 to 96% as compared to the chest X-ray, which is on the lower side is rubbishly 38%, goes all the way up to 76%. So undisputed winner here. So lung ultrasound is quite sensitive in diagnosing it. Now, mind you, pneumonia progresses through stages. It doesn't happen with the snap of a finger. So, there's a little bit of a brewing going on with the, viruses or the bacterias. And then as it progresses, the signs also progresses. So the ultrasound, the signs and the lines and whiteness you see on the screen, it's quite dynamic. It keeps on changing with the stages of the pneumonia. As in, you can imagine from the graph, which I have shared with you just now, as you start filling the alveoli or the segments of it, with the maybe with the fluids, or that areas started getting collapse, consolidated, you keep on seeing different signs arises as the pneumonia progresses. What happens? So as you start filling up with the fluid, the A line starts disappearing. That's what happened. A for air, and B lines is for the fluids. So as you start putting in more fluid in there, or you end up after you have more fluid in the alveoli, it starts collapsing. So there is no space for the air. So you start seeing disappearance of the A lines and the appearance of the B lines, more of the B lines, followed by the signs, the C profile, the consolidations, to the full-blown hepatization. So that is something which you will see in the upcoming slides. And as for the pathology 101, so hepatization is like lung starts looking like a liver. It becomes quite solid. So if you don't have air inside the lung, then you can see the lung with your ultrasound probe. Now, in a normal lung, when you fill with air, you only see the artifacts. When you have a full-blown hepatization, you reach that stage of the pneumonia, you actually see the lung, the lung tissue. And that is very understandably, it's called as a tissue sign. Again, I'm going to show you. Serial ultrasound is more informative, and it allows us to track the changes, towards the worsening side of the pneumonia, or responding to the treatment you are giving to that baby. So serial ultrasound is more informative, and that is true for any pathology in the lung ultrasound. You just don't do one lung ultrasound, as it doesn't come with the baggages of a chest X-ray of having extra doses of ionizing radiation. So you can keep on repeating as the clinical side of the baby requires. So serial ultrasound is more informative, and Doppler is quite instrumental in differentiating it from collapse. We will see that when we discuss the slides with the pneumonia. So Doppler is quite it's a trick up on the sleeve where we can use when we are trying to differentiate the collapse, which can happen in a number of neonatal pathologies. The ET tube 2 down, or ET tube in malpositioned or blocked ET tube, leading to the collapse of some part or some segment of the lung. That is not pneumonia. That's just plain simple collapse, because you're not being able to aid it that. And there's no way of telling the difference in the lung ultrasound until unless you employ or you interrogate that area with the Doppler. And we'll see how that helps. For all the people out there who believe in the evidence-based medicine, and also to satisfy the skeptics who keeps on asking why you need the lung ultrasound. So there is the evidences here. I'm not going to go through it, but there you see number 13, POCUS is helpful in detecting pneumonia in neonates and in children. And it is with the agreement of B quality, and that's where you see it's a moderate quality of evidence. So not yet A, but not rubbish like C as well. So you can use it. And as there is a plethora of evidences coming out, I'm sure it's going to move from B to A in near future. And these are the the papers I have listed here. So I'm sure you're going to get the recording of today's session, and you can very well go and read all the papers I have put out here. But basically, the idea is that it is not me saying or Alok saying it. There is an evidence. There's a plethora of evidence which says that it is much more helpful in diagnosing pneumonia compared to the chest X-ray. And you can keep on tracking it, Right. So my favorite picture here again. So how the signs, how do you get the signs which you get in pneumonia? So that's what we're going to talk about, and we will see the signs. So loss of aeration, which means loss of A waves. So A lines. So you start losing A lines. there will be alveolar and interstitial edema. And once you start having alveolar interstitial edema, you start filling that area with the fluid. So you'll start seeing more of B lines. Now, as the pneumonia progresses, so you start with only air in the alveoli, then you start filling it with the exudates or transudates. So you can have a mix of air and fluid. So when you have a mix of air and fluid, you can imagine in the lung ultrasound language. So air will give you echogenic area, bright white lines, and fluid will give you the anechoic area, which will be black in color. So you will see a mixture of white and blackness in the lung. So air and fluid bronchograms, and you will understand more once you see that picture. Then there is something called a shred sign or a fractal sign, and we'll see what that means. Usually people confuse the shred sign or fractal sign as a disruption of the pleural line, but it is not. It is not the disruption of pleural line, rather it's a irregular border of consolidated area. Again, we will see that on the slide. There will be a loss of pleural sliding. There will be a lung pulse. So as lung becomes more kind of a solid, from the air-filled sac to a fluid-filled, fibrinous-filled solid organ, I like to think it as a pudding on a plate. So once you pick, or the jelly on a plate. So when you put that on a plate and you wobble it, so the entire jelly wobbles. So same thing happens with the lung as well. So it transmits the cardiac pulse because it has become more kind of a filled with a fluid. You can imagine that this as when you do or elicit the fluid thrill sign in an ascitic patient. You tickle the one end of the abdomen, you can feel the trickle on the other hand, on the other side of the abdomen. So some similar kind of a thing is going on with the lung pulse. So it transmits the cardiac pulses, which is typically seen as a T lines on the lung scan. Now, this is an infection. So when you have an infection, so the body's defense systems needs to be there to fight off the infection. So how the mighty the white cells and the T cells reach the area. So they needs increased vascularity. That's how you reach the site of infection. So there will be an increased vascularity over the consolidated area. And that's where the Doppler comes and helps us. So you can imagine if it is a collapsed area, there is no infection, it's just a plain simple collapse. There's no need for the defense system to mount any kind of a reaction there. So you will not see any increase in vascularity in a collapsed area, which is plain and simple collapse, or not to confuse, plain and simple atelectasis. But if your collapsed area has consolidated, it's some kind of an infection there. So body will mount an immune reaction by increasing the vascularity to get your white cell, the white cells to get to the area. And increase in vascularity is a sign of pneumonia, which will be shown to us by the Doppler. And then as the pneumonia progresses, you can have a parapneumonic effusions, which will be a pleural effusion. It could be transudate, in variety pathologies, which are not pneumonia, or in case of a pneumonia, it could be transudate, or then the bacterial pneumonias, it could be exudate. So you will see the pleural effusion, and we will see how the pleural effusion looks in lung ultrasound. So this is quite an old guideline, and I still like it, and I put it here. I'll not walk you through the entirety of this, but I've just kept it here just to show you that what are the signs for the pleural effusions, what are the signs when we see the consolidations in pneumonia and atelectasis. So you can see the anechoic zone plus minus the jellyfish sign, or the sinusoidal sign and the quartz sign, that is for the pleural effusion. And we're going to talk all these signs, and we'll see how the pleural effusions look and how the pneumonia and the atelectasis are different from each other, how you can differentiate it. Right. Bronchograms. So what are bronchograms? When you do a chest X-ray, you see air bronchograms. Surprisingly, it's lung, and you have air in lung, so you see air bronchograms. When you do a lung ultrasound in pneumonia, you see something called as air fluid bronchograms. And we like to differentiate sometimes it as a static bronchograms and dynamic bronchograms. We'll see in the upcoming slides. So Air bronchograms is basically, air fluid bronchograms is basically something, as I explained, when you have a consolidated area, you have the alveoli or the small bronchioles feeding those alveoli is already with air, and there's a mixture of air and fluid there. And as I said, so air doesn't, the ultrasound waves doesn't like air, so it will give you anechoic area, sorry, echogenic area, bright white lines, and the fluid will give you the anechoic area, which will like black in color. So in this particular slide here, there are a lot of signs, but just focus on what we are talking through. So don't get reflected by any other things here, just focus in this area. So you can see acoustic shadowing. So those are your ribs. You can see those ribs. This is a small baby, so the entire lungs have come in one view with the with the linear probe. So those are the lung acoustic shadowings from the ribs. So this blackness, this blackness, this blackness is just the acoustic shadowing. So ignore that part. In between those areas, you can see this bright speckles. If you can follow my cursor, these are the white speckles, and they are sort of making a crescent around the anechoic area, the black hollow areas in between. So these are air fluid bronchograms. So the anechoic area, which is black in color, is filled up with fluid, and it has trapped some air. So trapping of air. So the trapped air looks like your bright white speckles. So those are the air fluid bronchograms. When we talk about the dynamic bronchograms is something which, as with the inspiration and expiration of the baby, there's some kind of a movement of the air, in the air fluid filled area. So you will see, appearance and disappearance of this white speckles. It's not very evident here, but you can see, if you can focus in this area, you can see the white speckles comes and goes. So as baby breathes, tries to breathe in, there's some movement of the air there. So it comes up. As the baby expires, it goes out, so it disappears. So as this white lines comes into existence and disappears to oblivion, so that is dynamic air bronchograms. If they are static like this, staying all over there, it's not changing anything. It's not changing its character here. So those are the static bronchograms. Yeah, you're following me?
Yes.
Brilliant. Now, to talk about the shred sign, this is also known as a fractal sign. As I said, this is just the irregular border of the consolidated area. This is not the irregular pleural line. So irregular pleural line is just, you called it as irregular or broken pleural line. There is no other name for it. But if you have the irregular margin of the consolidated area, which will always be an irregular margin, you will see that you call that sign as a shred sign or a fractal sign. And how does that look? Let's have a look. So this is the lung, and you can see white compact B lines. You can't see any A lines. As I have explained, as you progresses on the pneumonia, you start to lose the A lines and see mostly B lines. So you can see B lines, and you can very well see the elephant in the room over here, that it's quite broken. Yeah, it's quite broken over here. Now, people, why they confuse it with the irregular or a broken pleural line, because you follow the pleural line here and you said, it's broken here. But no, sometimes you can see this consolidated areas deeper in the lung. In that case, you don't see the pleural line. The pleural line doesn't go that deep. It's always superficial. So that's where the people make the confusion. Anyway, so that's your shred or fractal sign, and you can see the irregular border here, irregular margins here. So this irregular margin or irregular border is the shred or the fractal sign. Put the arrow there. So those are the irregular areas, and you can see the consolidated area. The central part of this area is sort of hypoechoic. Yeah, it looks more blackened. It looks more tissue-like. Yeah, it's not white. It's not white because it's not filled up with air. It's more tissue-like because it is more tissue. There's fluid filled. So you don't see if there's no air, it's not going to reflect the ultrasonic waves. So you see more kind of a grayish scale there. Whereas where there's a fluid filled areas, air filled areas, you see the white, whitening of it. And if you pay close attention to the central part of it, you will see the white speckles coming into existence and disappearing, which are called as the dynamic bronchograms. Right? So that's your shred sign. And those speckles, I put the arrow there, comes and disappears. And those are the dynamic bronchograms, air bronchograms. And the central part of it, the cleared area is your tissue sign. Right. So how does the color Doppler help differentiating the atelectasis or collapse with the consolidation? So the pulmonary arterial and the venous vasculature will be well demonstrated. As I explained already, why that's the case is because it's an infected area. And as we have, in the pathology, it's color, dolor, so color, temperature, perfusion, all that goes up. So your perfusion is going up, and that's what we're going to pick up on the Doppler. Let's do the Doppler here. So this is one of the area, and you can very well see here a well kind of a circumscribed area here, which has got dynamic air bronchograms in the center, and that's why it is. And then the central area is more like anechoic, quite dark gray to blackish, and that's the consolidated area. So that's not a collapsed area. How do we know it's a consolidated area? Because we did the Doppler. Now, that's quite significant blood flows. You can see the vessels coming up. So this is quite a significant blood flow in that area. Usually when you do a Doppler in a normal lung area, are you expecting to see any kind of a blood vessel? Now, I know it's a Zoom meeting, but yeah. So I'll give you the answer. So you don't expect to see blood vessels in normal lung ultrasound for a normal lung. And why is that case? Is simply because you will be Dopplering an artifact. There is no real vessel there. Yeah, because air is not a good conductor. It reflects back from the pleural line. So you don't get to see the lung. You don't get to do anything on the lung. So you don't get to see any real blood vessel. Yeah, so your lungs, the sound waves are reflecting back already from the pleural line, which will be from here. So in a normal lung, with the A pattern, with the A lines, you don't see the blood vessels. Yeah, if your ultrasonic waves are traversing the area, which means there is no air and it's filled up with the fluid, and there's a increase in vascularity, in only that case you will start seeing vessels, if any. Make sense? I hope it makes sense. Right. Another example. So this is pretty white out picture here. I don't know why it's not playing in a loop. Sorry about that. But you can see the smudged effect, and we can talk. There's some subpulmonic consolidations, bright speckles just down the pleural line in those areas, and you can see similar kind of a picture here as well. Now, I don't know if this is in the very beginning of the pneumonia, or is it just plain and simple RDSC or TTN kind of a picture. I'm not sure. I don't know. There's no way of knowing it. You can have a similar kind of a picture with the very initial stage of the pneumonia as well, where it's just brewing. So what do? We do the Doppler. And you can see a big throbbing vessel there. Yeah. You see a big throbbing vessel. And which clearly tells you, there is something brewing up there. Yeah. Although it's not a very clear fractal sign going on here. You can say that something is here, but you don't see that coarse kind of consolidation which you just saw in the previous slides. So it's a very initial stage here. and the only way to know that it is not collapse and it is a consolidation is by interrogating the area with the Doppler, which will clearly show you that there is a big throbbing vessel there. And so suspicion for the pneumonia is quite high. Moving on. The next sign is the pleural effusion. So in pneumonia, you can have a parapneumonic effusions, viral, transudative, bacterial, exudative, and what happens? So exudative pleural effusion in pneumonia. So there will be absence of pleural sliding. Again, very logically, if you could just go by step, so absence of pleural sliding. And why is that? Because your pleural effusion is in between your visceral pleura and your parietal pleura. So those are separated by your pleural effusion. So the pleura is separated, you're not going to see the sliding. And now because of that, your pleural, you're not going to see the pleural sliding, and your the visceral and the parietal pleura has been separated. You see something called as quad sign. Now, as the name goes, quad has 4 borders. So we see 4 borders sign. So I'll show you what that means. And there is something called a sinusoidal sign. Again, it's like a sinus wave, yeah, with the peak and trough. So we'll see that sign as well in pleural effusion. And if it is severe enough, very advanced stage, you're going to see something called as jellyfish and curtain sign. And pleural effusion, from the lung ultrasound standpoint, you can detect less than 5 mils of effusion, which is much, much more sensitive than a chest X-ray. There's no way you can detect less than 5 mils on a chest X-ray. So the point I'm trying to make here is in a very brewing stage of the pneumonia, you can pick it up with the lung ultrasound. Of course, your clinical context in the background will help you. And again, for the people out there, for the evidences, there you go. Number 19, POCUS is helpful to detect pleural effusion in neonates and children. Strong agreement with the quality of evidences, B. Right, so this is what you see in terms of sinusoidal sign. Now, just follow with me. So these are your ribs, yeah? And then you're not going to see a bad sign here for the very obvious reason. It's all fluid field. Now, fluid is a good medium for ultrasonic waves, and it helps propagating the waves. It doesn't reflect back, so it pass on whatever waves you're trying to throw at it. So big anechoic area, which is fluid filled. And then you see some kind of you might see, you might not, pleural line, and then there's a collapsed lung. As the baby try breathing in and out, this lung will move. Inspiration, so tries to move out or in, whatever word you want to choose. So it's moves towards the chest wall. Yeah, it tries to fill in. So it moves in and out. So this in and out movement, when you try to interrogate that area with the M mode, you will get a sinusoidal pattern. Yeah. So lung moving in, pick, lung moving out, draw. Yeah, so in and out. So that's what gives you the sinusoidal pattern. Okay, so you see a big pleural effusion, you run, interrogate that area with the M mode, and you're going to get this sinusoidal sign. You don't really have to interrogate when you see the pleural effusion to confirm that there is a pleural effusion, because that's a big elephant in the room. You see that very clearly as an anechoic area. But I'll come to it why we are doing it. So moving on to the quad sign, when you have seen the pleural effusion, so what exactly is the quad sign? Now again, here, that's your rib. That's your rib. This is one segment. Here should be your parietal pleura, and here should be your visceral pleura filled up with, in between, it's all fluid filled. Again, anechoic dark blue. It's propagating the ultrasound waves without any problem. And then it is hitting the lung here. Not focusing here, just focus in this part. And what is the quad sign? Now that's what the quad sign, rib and rib. You draw 2 perpendicular lines from there. So you got 2 borders. And then you have your parietal pleura, another border, number 3. And then you have your visceral pleura. That's what the quad sign is. I have told you in the last session as well, radiologists have a very stretchy imaginations because they sit in front of the black and white picture all the time. So we try to imagine all sort of things. So that's what the quad sign is. If you're trying to imagine where are the four borders, yeah, two imaginary lines and then parietal and visceral pleura. That's quad sign for you. Sinusoidal sign, as I've already explained, is when you are interrogating those areas with the M mode. So those are your ribs, yeah, and then this the sinusoidal movement of your lung in and out. So pick and draw is your breathing in and breathing out. Curtain sign. What is curtain sign now? So, sorry. I don't know why it's not playing. Right, I'll just explain that to you. So that's the last pleural effusion here, black anechoic. And then that's your liver. Yeah. And as the baby tried to breathe, inspiration and expiration, this pleural effused area, which is dark black in color, is covered with something. Yeah. So it's like the curtain coming in the, like you draw the curtain. Yeah. So it's like drawing the curtain. So as the baby expires, so this his bit of lung come in the picture and goes out of the picture. I have more slides to show you in real time. Just bear with me. Again, jellyfish sign. So what is jellyfish? Now this is the same slide as I've shown you in the beginning for the bronchograms. We focused here. Now try to focus here in this part. You can see the tip of the lung. Now, because this is a premature baby and the entire lung has come in one slide, just imagine this is a big, grown term baby, or for that matter, it's a pediatric, toddler or a kid. And you are just focusing on this part. Yeah, you're just seeing this part of the lung. What are you going to see? Something is wobbling about in the fluid filled area. Yeah, something is tickling about in the fluid filled area, that wobbling movement. So that wobbling movement, it looks like one of the arm of the jellyfish. Make sense? Just try to imagine things like radiologists do. So that's wobbling movement of the tip of the lung in the fluid filled area around. So that's a jellyfish sign. And um, I mean, just cover the rest of it with your hand on your screen and you will see what I mean. If you cover with the hand, and you will only see the tip wobbling about on that particular segment. Yeah, so that's a jellyfish sign. And as you can see, it is moving more towards your what do you call towards the in and out movement towards the parietal pleura. If you're focusing only this part, you will that's what constitute the curtain sign as well. It comes in your picture, in your field of view when you are scanning the baby, and it goes out of the view. So if once it moves in and out, that particular sign is called the curtain sign. So it depends on which part of the the segment of the pathology you are looking at. Now, this is a preterm baby. You can look the entire lung in one picture. So it's, it looks a bit different, but that's the jellyfish. Now, on the same picture, you can see that this part of the lung, you can actually see the lung. You can see that lobe of lung, isn't it? And it looks more like this. Now, this is your liver. Yeah, that's your diaphragm. That's your liver. And your lung looks like more like liver. Yeah. And we know from pathology, the advanced stage of the pneumonia is hepatization. And that's what hepatization means. So your lung lobes looks like liver on your lung ultrasound. So this is hepatization in pathology, and we call this as a tissue-like sign. Yeah. So it's like a liver tissue, this entire lobe. Here, what's going on in this part of the area? So this is here, like you have, of course, you can see the B lines here, the stretch signs, the fractal sign. You can see, if you focus in this part of the scan, you can see as the baby inspires, the air moves in, and you see the dynamic air bronchograms, bright white speckles coming in the view. Just focus in the where I'm putting my cursor on. So it comes on and it disappears. So dynamic bronchograms there. Yeah. And this is all fractal sign. So this is not irregular pleural line here. It's a fractal sign. It's all consolidated area. And this is the area where you have entrapment of the fluid in the air. And You can see the lung. Why you can see the lung here is because your ultrasonic waves has been enhanced or augmented the propagation of the waves by the fluid filled area around the lung. Hope all that has made sense.
So where do we keep the probe to see this kind of picture? If we're able to see diaphragm, liver, and like.
So as I said, this is a premature baby, extremely small baby. Less than now I don't remember how what was the weight of the baby, but it's definitely less than 1,000 grammer, and you can see the entire lung. Now, when you're dealing with the bigger babies, you put your probe perpendicular position. When you see any abnormality, you have to do both the perpendicular and the longitudinal, which means vertical and the horizontal scan both. I'm sure Alok's going to talk about that or might have spoken about it on the basics of it. But where to keep the probe, you just go by the standard areas what we scan, and in any area where you see there is some kind of a pathology, you see anything abnormal, now you try to interrogate that area with both vertical and the horizontal scanning.
Okay.
I'd like to double check if there is any difference between the fractal and the shred sign, or both are the same.
It's the same name, yeah. Fractal sign is the shred sign.
So just
Thank you.
coming in to answer Surjit's question. So the probe that is used is also quite important in that this is basically a probe that's kept perpendicular, but it's a linear probe with a very large footprint, which is why you can see multiple rib spaces. So, it's the probe that is used, the linear probe with a large footprint in this situation really helps.
Yep. Right. Moving on.
Sorry.
I'll explain. Again, another baby, similar kind of a picture here. So these are the ribs. Again, this is the same probe. You can see here the linear probe. Again, as Alok mentioned, it's a big footprint with a small baby. So you cover the entire chest of the baby. So these are the ribs. The probe has been placed perpendicular on a vertical position. Yeah. And then this is the picture you got. So fluid filled. So that's a pleural effusion. You don't need to interrogate that area with the M mode to see the quartz sign or to see the sinusoidal sign. You can very well see that's a pleural effusion. Yeah. And now what you can see here, all these areas are white speckle lines. Again, they comes into existence like a tree. There you go. It branched out like a tree and then it disappears. It comes again like a tree and it disappears with the inspiratory and expiratory movement, the classical example of the dynamic bronchograms. Again, air reflects the ultrasound waves, so you see white speckles. Yeah. There is not much of a fluid in this lung. As in like this must have been filled with the fibrinous trend in the pneumonia. So quite an advanced pneumonia there. So you don't see air filled bronchograms. You can see some over here. You can definitely see some over here, but in all these areas, it's just coming up as a white speckle as the baby try to breathe in air. Yeah. And again, if you focus on this particular area, you will see the jellyfish sign and the curtain sign as well. The spine sign.
Please.
Yeah.
If we have a lung collapse because of a chylothorax and it's not because of infection, this means that we're gonna find consolidated lung, collapsed lung, which means with static air bronchograms and no Doppler, or the Doppler would be negative then, if it's a chylous pleural effusion, not infective pleural effusion.
Sorry, I didn't get the whole part of the question, but I think if I've understood right, if it is a chylothorax, do we see the blood vessels on the Doppler? Is that what you mean?
Yes, exactly, and there is no shed sign definitely. So would it be just collapsed lung with static air bronchograms and no positive Doppler on the Doppler examination?
Yes. Yes. So if it is a chylothorax, you're going to see similar kind of a picture as you are seeing here. Because at the end of the day, is it a chylo, transudate, exudate, or for that matter, hemorrhage? It's a fluid. Yeah. Until, the hemorrhagic fluid has reorganized. I'm going to talk about it on the pulmonary hemorrhage section. But anyway, at the end, the bottom line is those all are fluid. Chylous, transudate, exudate, all are fluid. So any fluid on lung ultrasound, black. You see blackness. Okay, so that's anechoic area. Now, how do you see the lung beyond that? If it is a pneumonia, if there is a consolidation, you will see dynamic air bronchograms. To begin with, you might see static air bronchograms. As I said, it doesn't happen with a snap of a finger. But if there's a pleural effusion, you know that it's quite advanced. Forget to paranumeric effusions. It might be slightly different if it is a viral one. You can start getting it quite early. But so you will see dynamic air bronchograms in the lung, in the area of the lung, if it is a pleural effusion due to pneumonia. If it is chylothorax, then do you have pneumonia with chylothorax? Might be, possibility. Do you have a normal lung with chylothorax? Absolutely. If it is due to some other reasons, we just got a chylothorax and no other lung pathology, it's a normal lung. Are you going to see any conglomeration of the blood vessels there? No, your lung is normal. So as soon as you hit the pleural line beyond your fluid, chylothorax, you're going to reflect all your lines back. Yeah, you're going to reflect all your ultrasounds sounds back. So it's not going to show you any blood vessels.
Yes, okay. Thank you very much.
Thank you. Right, so what do we see here? Again, this so spine sign. Again, if you look closely here again, this is fluid, clear, anechoic, so it's a fluid. These are the ribs. Again, if you can draw the imaginary lines, you can see the quartz sign. Again, coming from the very basics of ultrasound, fluids propagate waves, and it hence augments the waves, so it passes all through. And what do you see here? I don't see any lung here, and that's your spine. Yeah. Had there been lung filled with air, all the waves would have been reflected back, and you will not see the spine. There's no lung. Or even if there is a lung, in some cases in pneumonia, there would be a lung, but then it would be like a tissue-like sign, and it can still propagate the wave, and you will end up seeing the spine. And that's what the spine sign is in pleural effusion. Makes sense? These are the vertebral bodies here. So spine, because your ultrasonic waves are passing through it unhindered. It's not being reflected back by any air pockets because there is no air pockets here. Yeah, it's reaching the spine of the baby. Now, if anybody can tell me what part of this lung is and what this thing is. I mean, without the clinical background. Anyone? No? Well, I'll just tell you. So this is a baby post-operative from the CDH, and you can imagine it was filled with the abdominal content which has been pushed back, and of course it's voided area. There's no lung here. That's the CDH. So if something has to be filled for an empty space, so the fluid has filled in the space. That's why you're getting pleural effusion there. And it will stay until the lung grows and pushes the fluid out. And this particular area you're seeing is the Gottix patch, for the large type C defect repair. Anyway. Now, these are the different kind of effusions and how they look on the ultrasound. If it is a transudate, it's a clear fluid. So you're going to see an echogenic black, absolutely black area. And you might see sometimes strands, so complex non-septated one. If it is an exudative fluid, which basically means you have a lot of cells in it, you have a lot of fibrinous strands in it, so you will see a dirty looking floaters in the fluid. You will see the bands and the floaters in the exudative fluid. In hemorrhagic one, it's been ticked on the echogenic area. So, but mind you, when there's a fresh bleed, it is just fluid. Yeah, it's like any other fluid. It is like a chylothorax or a transudate or an exudate. If it is a fresh bleed, you're going to see an echogenic blackened area, like any other pleural effusion. Till the time your blood has started reorganizing, it started making the clot. Once it forms the clot, you're going to see the white echogenic reflection. Making sense? So hemorrhagic, at the very beginning of it, once the fresh bleed, you see an echogenic, but once it matures, it starts reorganizing the clot, you see echogenic. Pulmonary hemorrhage. So clinical context is the key. Now, there is no surprises here. Going back to the I have not put the slide here again, I think. No. So going back to the air fluid curve graph. So the pulmonary hemorrhage, you're hemorrhaging blood into the pulmonary area. So you are replacing the air with the fluid, which is the blood in this case. So you're going to see exact propagation of the same signs. Okay, so you start, the A line starts disappearing, the B lines comes in the picture, and depending on how bad is the pulmonary hemorrhage, your ultrasound picture is going to worsen. So clinical context is the key. Is there is a blood in the ET tube or in the suction, and then you do a lung ultrasound, and you're going to see exactly the same sign as you have seen in the collapse or consolidation. Okay. I know the question that comes here is, oh, are we going to see the, if you Doppler the area, are we going to see the vessels? Well, no, you're not going to see the vessels if the pulmonary hemorrhage is only pulmonary hemorrhage and there is no consolidation. Yeah. You're only going to see the signs of collapse or the atelectasis, more of B lines, compact B lines, white out lungs. Yeah. So that's what happens in pulmonary hemorrhage. There are no special signs to talk about in pulmonary hemorrhage. Just in terms of pneumonia or the effusion, there are fluids, and in hemorrhage, that fluid is blood. All other signs stays the same. And again, there are evidences. It's a growing evidence. As the days goes by, the publications coming out, and we are talking about all different signs we see on the lung ultrasound in terms of pulmonary hemorrhage in newborns. But clinical background and the context is the key in diagnosing. I have put some practice slides, and it's quite challenging on a Zoom call to go through the practice slides, but I've kept it anyway. I thought I'll just talk you through this, and rather than asking questions, so that you see more of it and you know what the differences are. So I'm just going to talk through, and if you have any questions, we can discuss it at the end of it. So this is without any clinical background. So this is a scan of a baby, lung ultrasound, and you can see the pleural line. Okay, and then you can see the B lines, which has become compacted. And I don't have to tell you here, there's something wrong going on in this part of this segment of the lung. There is sort of an anechoic area coming in the picture, looks more like a lobe or a tissue-like sign there. But then I don't know, it might be just a collapsed area. But then it looks like a, broken, you can say broken pleural line, or it could be a fractal sign, irregular borders there. What do we do? This is what we do.
Doppler.
Yeah, that's what we do. And when you do the Doppler, you're trying to look for the vessels. You can see the vessels coming in the picture there, feeding into the area. And well, this is not plain simple collapse, it's consolidation. And if you look at macroscopically here, you will definitely see the areas where it's popping off as bright speckles, the dynamic bronchograms. Next one. Again, not a very good quality of a scan here, I beg your pardon, but we can see what we want to see. So pleural line, very gross, I would say. It's not discrete, it is not smooth. It is kind of an irregular, smudged out effect. I cannot see any A lines, maybe some here, but it's mostly B lines, and it disappears, the A line disappears. And I can see some subpulmonic consolidations, the bright speckles here. Any guess with the diagnosis here? If I tell you this is a baby, 32-weeker, born incomplete steroid boy baby.
RDS.
Yes.
Absolutely. That's correct. If I tell you this is the same history, the baby is on 25% of air, are you still going to say RDS?
No, maybe a transitioning lung.
Transition.
This is 1 hour-old baby or 2 hour-old baby.
Yeah,
25%.
transitioning lung. So we need to do a serial ultrasounds to see if there's going to be a double lung point or aeration.
Okay, so this is the same baby. I have done the scan at 4 hours of life, and this is the second scan. Baby is on 25% of oxygen.
Still on 25?
Yes.
And he's not distressed?
He's on CPAP.
Maybe we'll wait a little bit.
Yeah.
Again, the transitioning lung, because sometimes TTN could take up to 72 hours to resolve.
Right. So I have seen this is okay. I'll not prolong the question answer session here, but yeah, the point I'm to stress here is if you see this kind of a picture in entirety in all of the lung zones, irrespective of what your oxygen concentration, it might be 25 or it might be 29.9%. It is RDS. If you see uniformly this picture in all the lung zones, yeah, this is not TTN. People might say, oh, the baby is on, 25% or 29.9%. It's not hit the 30% magical number.
Yeah.
But don't worry, that will be RDS because the signs in the lung ultrasound precedes the FiO2 requirement in babies. So this baby is not requiring now, but later on, who knows, after 72 hours, might be heading for an intubation. Right. Again, another scan.
TTN.
TTN, that's a double lung point, no brainer, excellent. So I'll not go through that again. This one is
It's pneuma.
sorry, I didn't catch that.
This
I
is
think it's
pneumothorax.
pneumothorax.
And that's the whole reason of keeping this slide here. This is not a
Oh,
pneumothorax.
it's on the
But it's
tail.
lung slide.
So if you
Lung
see any vertical projections from the pleural line, name it like, comet tail artifacts, B lines, how you want to name it, for the purpose of diagnosis, not going by the semantics or trying to be very, dogmatic about the nomenclature of these lines. If you see any vertical lines projecting from the pleural line, there is some kind of a fluid there. If there is a fluid in the alveoli, there is a lung there. So it's not a pneumothorax. Yeah, it's a well aerated lung. That's why you see the mirror image artifact. Yeah, on the both side, the pleura. So it's a well aerated lung. Or maybe if this baby is on a CPAP, the CPAP is too much for this baby. You can clamp down on the CPAP from 8 to 7 or 6. I don't know. But it's a well aerated lung or overexpanded lung. But it is not a pneumothorax. Any vertical projections from the pleural line that gives way that is not a pneumothorax. If you don't see these projections, again, I'm not going into the details of is it a comet tail artifacts or is this a B line? Who cares? There is some projections coming from the vertically from the pleural line, which basically tells you there is some kind of a fluid there, which means there is a lung there. So no pneumothorax. Moving on.
So mirror imaging could be seen in a well-aerated lung, not just the pneumothorax. Mirror imaging, I mean.
Do we see the mirror image in a well-aerated lung? Is the question?
Yeah, like I thought mirror imaging is seen in pneumothorax.
Not exclusively, no.
Yeah.
Yeah, you can see in a normal lung as well, or a well-expanded or overexpanded lung. Yeah. Point I'm trying to make here is if you see a pleural line and there is a vertical projections from the pleural line, if you see some vertical projections coming out, it is not a pneumothorax. Yeah.
Yeah. Thank you.
Right. And if you have a confusion, you have something, one trick up your sleeve. You can do something over here to find out if it is a pneumothorax.
M-mode examination.
Excellent. And you try to look for, is it a sandy pitch or a barcode sign?
Yeah.
Brilliant. Another scan. I'm sorry about this, why I'm having this red thing here. It's not a part of a scan at my computer. Okay. Again, that's the ribs. That's a discrete, nice and discrete pleura here. A lines comes up on this side of the scan. There you go. And on the caudal side, so that's the cranial side of the baby, and on the caudal side, you can see some kind of collapse or consolidation going on. Yeah, the fractal sign, broken margins, irregular margins. And then what do? I do Doppler, and that's what we get. The vessels coming in the picture. You might ask which is the vessel here. So all this, ignore this markings that comes up like that, comes in appearance and disappearance. The vessels looks like a long cylindrical tube. And you will see better on the next one, maybe. Again, this is collapse or consolidation. Tissue-like sign in the center, hypoechoic, and then that's a fractal sign there. That's what you see when you do the Doppler. Throbbing blood vessels. Ignore this red line here, and those are the throbbing blood vessels feeding to the consolidated area, telling you that something is brewing in there. This is not plain simple collapse or atelectasis. This is a consolidation. There's some infective process going on there. Moving on. What do you think of this?
Might be a
There's no
pneumotorax.
no lung sliding. This is pneumothorax.
Excellent.
Absence of slide.
Yeah, that's a lung pulse going on, which you think like it might be a pleural sliding. So that's a lung pulse. And I don't see any vertical projections. If you see what I mean, there is no vertical projections. Yeah, you can see only A lines. So that's pneumothorax. And of course, you will do the M mode on this. Anyone about this one?
Lung
Pneumothorax.
point. Lung
Yes,
point.
lung
Double lung point.
Yes, that's a lung point and that's a pneumothorax. Normal lung here. That's why you see vertical projections. Yeah. So that's your lung. And you don't see this on this side. Yeah, because there is no lung on this side, just filled with air. So pneumothorax. Transition between the two is your lung point. That's a lung point. And of course, you do an M mode. Right, let's talk about this baby. So this is a baby. Give it some gestation, 32, 34 weeks, intubated, tube, high riding tube, and the ET tube. So in the morning handover, we got a bad gas. The nurse told us the gas is worsened. There is a CO2 retention. And of course, the next step was to do a chest X-ray to see what has changed. And this X-ray was done. And that's the elephant in the room. And that's what we see. What do we do next is the question.
Ultrasound.
Right.
Ultrasound. Lung ultrasound to differentiate that collapse or atelectasis or consolidation.
Yes. So if you don't have a lung ultrasound, what would you have done?
Restrap the tube, push it a bit downward.
Yeah. And then re-X-ray.
And sorry? What?
And then re-X-ray, put the tube down, right side up of the baby, nursing, and then re-X-ray the baby.
If we don't have an ultrasound, we might re-X-ray him, but we should give him some time because I think it will need some time because of the radiological lag between what's actually happening and the X-ray.
And
Yeah.
peak as well.
And if you don't see any changes after all your steps,
I will make physiotherapy and suctioning.
Yeah, it could be secretions or something.
right. Good. So I have saved you so much of time and your effort in your neonatal unit, thanks to Alok. Right. What do? You do a lung ultrasound. And once you do lung ultrasound, this is what you see. You can see that's an R1,
Yeah.
right side, 1.
Oh.
Nice aerated lung.
Yep.
Yeah. And then I try to tilt the probe a bit. Still in the R1 area. That's your heart. I'm tilting the probe. Excuse me.
Is it just a thymus?
This is what we see.
Stimulus.
Thymus. Excellent. So once you know that's a thymus, what do? Ignore. Let the baby in peace. And it saves you so much of time. And doing all sort of stuffs. So you can see the importance here. I'm not saying that, you never see, in this kind of a situation, you never see collapse. Most commonly you do see collapse. Yeah. If you have a high riding tube, that's the area more prone to collapse. And plain and simple collapse, no consolidation, just a collapse there. But then if you have a lung ultrasound, you can just, run over it and we'll see, oh, there's a thymus there giving you this picture. Otherwise the lung is well aerated. I don't see any crowding of the rib. If you see what I mean, if there has been a collapse, I would be expecting to see some kind of a decrease in what do you call this, interrib spaces. But no, you don't see that. So you can relax and you say like, okay, just push the 2.5 centimeter in and just let the baby be. All right. And just highlighting how it can help you on a regular ward rounds. Right. Next one. Now, somebody asked me the question. Sorry, I don't know who asked me because I can't see you guys. Very sorry about that. But one of you have asked me about the chylothorax, and then how the lungs looks like. Do we see, vessels, or do we see, if we Doppler the area, do we gonna see any vessels there, or if it is might be a normal lung or that might be a collapsed lung. So to answer your question, this is the slide. So this is a baby with the chylothorax. All right, so this particular baby is with the chylothorax. You can see it looks black. Chyle is white, but to ultrasound, it is black because it is a fluid. Yeah, so black area, anechoic. So, and you will see all the signs we have talked about in pleural effusion. At the end of the day, chylothorax is also a pleural effusion. But interestingly, what do you see? This baby's lungs is absolutely grand. It's normal. Yes, there is some kind of a pressure effect from the fluid. That's ought to gonna happen because there's a fluid pressing onto the chest. But you can see that's a pleural line. And then you can see I don't have to tell you guys now, you guys are expert now. So these are the white, the horizontal reverberation artifact called as A lines coming in the picture. Make sense? And
Yes.
some, B lines, which can be normal, is there. Yeah, so this is what a normal lung with the chylothorax looks like. You don't see collapse or you don't see consolidations. Yes, of course, you might have collapse with the chylothorax. You're going to see collapse with chylothorax. Or if you have a pneumonia with the chylothorax, you might see the pneumonia with the chylothorax. But this is what the normal lung looks when you have a chylothorax. Hope that I've answered the question.
Yeah, that's clear. I have a question about the pleural line over here. Shall we consider this a bit thickened or showing some pleural consolidations? Or no, it's okay.
No, I will take that with a pinch of salt. Why? Now, just see that this is only the L3 area I'm talking about. You never conclude on any pathology or the lung status just by one zone. You have to do the thing when you have seen the pleural effusion, you're not going to skip the other zone of the lung. Yeah. So you're gonna go into the detail. You're gonna do all the areas of the lung, and then you're gonna shift your focus. Now your focus is sitting somewhere here of the lung. Okay, because that's what you have seen. And like you are very delighted with your scan. Oh, I have seen a pleural effusion there. But now you need to focus, because the pleural effusion will help your ultrasound waves to traverse all throughout the lung. Yeah, so you're gonna shift your focus of the lung ultrasound from this part of the zone to this part and try to concentrate here to find out, is there a collapse, is there a consolidation, or am I dealing with the normal lung here? So when you do that, your pleural line if it is a normal lung, it will become very discrete, smooth, sharp, white echogenic line. And if you're dealing with some kind of a pathology here, collapse or consolidation, that's what you're going to see, a broken pleura or a fractal sign or a shred sign. And the bronchograms, the signs of collapse or consolidations. So you have to see all the zones and you have to interrogate the area more in depth rather than just being happy about seeing the pleural effusion and ignoring the rest of the lung.
It's okay. Thank you.
Yeah.
Could I
Lovely.
ask you?
Yes.
Tell me, please, in your practice, if you see now pleural effusion, do you have some criteria for pleural puncture? Besides, and if you have this criteria, where do you measure?
Abhijit,
Yes,
I'll cover it in the talk on pleural effusion. Don't worry.
Okay, no worries. Okay, there you go. Alok's going to give you that one. But just to give you one statement answer, yes, you can measure the pleural effusion. It's a very simple technique. How much is the fluid volume there? And depending on what's the respiratory status and the clinical background of the baby, you end up draining that effusion. But I'll leave that with Alok. Anyone?
This is diaphragm.
Diaphragmatic excursion.
Function of the diaphragm. Diaphragm thickness.
Sinusoidal movement of the diaphragm during respiration.
Yeah, you guys are expert. You don't need me. Right. So this was a trick slide. Well done, guys. And why I have put it here, not to trick you, of course, but to show you the difference between how the pleural effusion and the normal diaphragmatic excursion looks like. So you guys already ahead of me, you know it. So you're gonna see the sinusoidal pattern. Anything that moves inward and outward movement for a machine, you're gonna get a sinusoidal pattern. Yeah. And the difference between those two is you see here grayscale because that's your liver, and here you don't see that. It's anechoic, so you see black on your M mode interrogation. But we're not going to cover the diaphragmatic excursion here, and that's a completely different topic to decide on. How the lung is behaving and is the extubation ready and all that. So I'm not going to cover all that, but you see the difference how the pleural effusion and your diaphragmatic excursion looks like. Okay. Well done, guys. Okay, next one.
AIS.
Okay, you will need a bit of a clinical background here. Preterm baby, 28-weeker, born 2 hours old on a CPAP, needing around 35% of oxygen.
There is
RDS.
no
RDS.
subpulmonary consolidation. There is no subpulmonary consolidation and good sliding. AIS maybe تبقى transit tachypnea pneumonia.
Yeah, and can you see something else in the picture?
Some fluid.
Fluid.
Yeah,
Yes.
sliding is not that clear.
Sliding is, well, I will not talk about the sliding here, and you don't really have to, because if you're seeing a confluent B lines, there has to be some fluid there and lung must be sliding in there. Of course, you can, if you have a doubt about it, by all means do the M mode and you're going to see the sky, sea and beach, sandy beach appearance and not the barcode.
Can
The
it
point
be a basic RDS?
yeah, it looks like an RDS to me more than TTN. But again, you have to see this homogeneous picture in all the lung fields bilaterally, because RDS is a homogeneous disease, unlike TTN. And at the same time, you can see some pleural effusion, which goes more in favor of RDS than towards the TTN. Yeah.
TTN.
This looks
That's
like a
it.
double point.
Yes. So you can see the difference here. So this is a non-homogeneous picture. Whiteness here, well aerated here. Whereas if we go to the previous one, this is a homogeneous picture. Because surfactant deficiency is global. It's bilateral. It's both the lung, all the zones affected. TTN is not. Your the upper zones are well aerated compared to the basal zones. So the cranial end of the baby well aerated than the caudal end. Right. So again, I will not trick you with this one. This is again another homogeneous picture which you see in the RDS.
RDS.
What about this one, guys?
Barcode? What?
Barcode sign.
This is a trick question, guys.
Yeah, because it's
Nothing.
a
Where's the
little
lung?
different.
It's a drone.
Sorry.
Drone.
We can see with a big smile on my face.
Probe.
It is a definitely trick question. Any wild guesses what it could be?
Bottle of
Is it
champagne,
just
if anybody
one
can
there?
guess. Bottle of champagne, if anybody can guess.
The both looks like a mirror imaging, sir. Just it is little less
Gel on
echogenic.
probe and mode.
Right. So this is, guys, okay, this is none of those. So this is what happens when you condition our brain to look into something, and it's a good thing. So when we're learning lung ultrasound, we try to identify the pattern. So that's where you guys are getting on. And you are rightly talking about, it's a reflection, or the modes, M mode interrogation and all that. That's a very good sign of progress you guys are having. But let me tell you, apart from doing medicine and neonatology, I'm a big, fanboy of Neil deGrasse Tyson, and I'm very much into astrophysics. So this is actually a ring of Saturn shown by the Cassini probe before going into oblivion into the atmosphere of Saturn.
Right.
So this is nothing to do with the lung ultrasound, but I'm glad that you guys are seeing lung ultrasound everywhere. So that's a very good sign. Well done, guys. So that's me. That's me. Just keep calm and keep on scanning. As you keep on scanning, you will keep on seeing the signs. You guys very well are. And I'm happy to take the questions. And that's me for today. I hope I have done within the time frame, Alok, today.
Yeah, perfect. It's absolutely perfect. We've got some nice questions, Abhijit, in the chat.
Yeah.
So we got a question from Satish. So if a preterm baby is on CPAP and there's a double lung point, would this differentiate TTN from RDS to decide for surfactant?
CPAP baby on, preterm baby on CPAP.
Yep. So not intubated, and
Uh-huh.
we can see a double lung point.
Right.
So would this kind of be pathognomonic of differentiating TTN from RDS to decide on surfactant?
No. So the question again is, it depends on how much of respiratory support you are giving. I don't like to quote the FiO2 requirements because it tips the balance. If you see a double lung point, okay, so you got a preterm baby who's on a CPAP of 8 centimeter, needing it around 21 to 25% of air, and you see a double lung point. From the lung ultrasound perspective, that's TTN. Okay, if you are seeing a double lung point on a preterm baby, you know that this lung is not homogeneous. Some areas are well aerated and some are not. So why do you see a well aerated area of lung in a preterm baby anyway if it is a RDS? It's homogeneous, it's global. You should be seeing whiteout lung or near about whiteout lung in all the lung zones. To take you out of that sticky situation and give you objectively, irrespective of what I'm saying, to give you an objective answer, employ the lung ultrasound score. So it's been developed by the Raimondi et al. From Italy and Spain. It gives you an objective number to say that, okay, the number is more than 8, the score is more than 8, this baby needs surfactant, or the score is less than 8, this baby doesn't need surfactant. So yeah, I'll go by scoring at on those instances. Yeah.
Lovely. We've got Satish's hand raised. Satish, please go ahead.
Thanks, Abhijit, for the excellent session. My question is, when you do the interrogating by color Doppler, whether it's consolidation or not, what should be the ideal color scale? Because on the different slides you have shown, the color scale was kind of, not same.
Yeah, it's a different. So I will not talk about the higher color scales. It's more about the lower one. So you want to keep it anywhere between 3 to 5 at least. You don't want to go below that.
This is a very important point, Satish, because the risk of using higher color scales is you will then start getting vascularity everywhere and you get a lot of speckling as well. So Abhijit is right. The only other thing that I would say is that whenever you use your color within a window, try to keep your window still. If you keep moving your window quite a bit, often you will get a lot of speckling with the color scale as well. So keep your window still. Very important.
Thank you. Sorry. Thank you both. Just to clarify, so the ideal color scale is 3 to 5. Is that okay? Thank you.
Yeah. So what happens here is, why I said the lower color scale is important, because sometimes when you are scanning and, you might see a lot of speckle and it becomes difficult to differentiate, oh, am I seeing speckle or am I actually seeing a vessel? Yeah. So you are on top of it. You can definitely see a consolidated area. So now you are in a double mind. Am I actually seeing the vessel or the speckling? Try going up on the scale and try to figure out, try to take the speckle out. But you always start from because it's a low pressure system. The lung is a low pressure system. So always start from 3 to 5. And if there is a need, go up. Full blown fulminant, pneumonia there, good going consolidation.
It'll be obvious.
It'll be obvious. You will get it even if you go up on the scale.
We have one more question, Abhijit. Is it possible to identify visceral pleura in a pleural effusion? This is Dr. Alberto Berengua.
Right. So I would rephrase that. Is it required to identify the visceral pleura? Are we going to gain any information out of it? Well, really, no, we don't. And the pleural thickness are in millimeters. So you don't really identify parietal and visceral pleura. You cannot differentiate. You don't have that kind of a resolution with your probes, at least so far till date, that you can delineate that millimeter of thicknesses. So and on top of it, we don't have to. Why do we need to? If it is sliding, you're going to see the sliding sign. If it is not, if it is separated by the pleural effusion, that's the end of it. That's a pleural effusion you can see in front of your eyes. So we don't have to. And with the resolution we have right now, we cannot differentiate between the parietal and visceral pleura.
So I have a question from Naveen Atraman. Do you see blood vessels only in infected areas?
Yes. And as I've already mentioned in my slides, that why do we see only in the infected areas? Number one, normal lung. Let's talk about normal lung. If it is a normal lung, all of your ultrasonic waves will be reflected by the pleura. That's clear. So if it is everything is reflected back, you can't Doppler the air, can you? Or you cannot Doppler the pleura. There is no vessels there, can you? So no vessels, normal lung. That's out of the way. Question is collapse and consolidation. If it is a collapse, you have some segmental, collapse of some part of the lung. Now, there will not be an immune response to it. So no increased vascularity. There will not be any increased flow there. What happens in collapse? Again, going by the very physiology and pathophysiology, hypoxia in that part of the lung. We know lungs have hypoxic vasoconstriction, not dilation, as contrary to the rest of the body. Hypoxic vasoconstriction. If you're constricting your vessels, are we going to see any flow there? No, that's your collapse. No blood vessels. Now the consolidation. How do we see consolidation and the blood vessels there? Now, this part is not collapse. It's a consolidated thickened area, infection. The blood vessels have of course, there's element of hypoxia there, but then there are tissue factors releasing there, which is dilating your vessels. So vasodilation is going on, and the more flow, the more dilation, there's more flow going on there. Hence, you see the blood vessels become very evident in the consolidated pneumonic patches or the areas. I hope that has answered your question.
I have a
Thank you.
Go for it, Dr. Marwa.
Can we use the lung ultrasound in assessing the lung hyperinflation? I mean, do we have solid signs like you've mentioned earlier? If we have a mirror image with comet tails or B-lines coming from the pleural line, this means definitely that it could be a baby that is a bit hyperinflated, overdistended, and we need to come down with pressures. So do we have like fixed or solid signs for hyperinflation or to assess the lung hyperinflation, I mean?
No, the answer is no. Still, we don't. There have been studies trying to do that, figure out that. There's a Canadian group who's mostly on it, and they try to do it. But for all practical purposes, at this point of time, the answer is no. And I think the message has got lost here. I'm not saying that, when you see vertical lines there, you have overinflation. What I'm trying to emphasize there is if you are seeing a vertical projections coming down from the pleural line, I don't care if it is a lung comets or lung rockets or B lines. There is some lung there. So that's not pneumothorax is what I meant. But you are seeing a mirror image there. So what can give you a mirror image? A normal lung can give you a mirror image. A hyperextended lung can give you a mirror image. Yeah. Mirror image basically what is the meaning of mirror image or a truck sign, lorry sign, howsoever you want to name it. The reason behind the generation of that image is you have a very highly reflective pleural line, because just beyond that is filled with air. So it's well aerated lung field, or there is no lung at all. There is just air. So basically, you need something which will reflect your ultrasonic waves, and that creates a mirror sign. So you can have that in a normal, well aerated or well expanded or over expanded lung because it's filled with air, or you can have that in a pneumothorax. Okay, but it is not mutually exclusive. So if you have a mirror sign, you can't say that this baby has got a pneumothorax.
Yes. Okay. Thank you. Yep.
We have time for a few more questions. Anybody else?
Yes, please, Alok.
Yes, please, Dr. Ashraf. Please go ahead.
Sometimes when you make a scanning, all criteria of athletics is there, but I found increased blood flow. This is the one. Sometimes برضه static and dynamic bronchogram, maybe in the static area or also in the concentric area. This can happen. يعني
If it is a pure atelectasis, you should not be seeing vessels there, the plethora of vessels, because why should we be seeing a plethora of vessels in an atelectic area if it is a pure atelectasis, because of failure of aerating that part of the lung? As I have explained physiologically, that segmental area will have hypoxic vasoconstriction. So there's no question of getting, more blood flow in that area. And that's what VQ mismatch means, if that makes sense. So VQ mismatch is because of that, because that area has collapsed. So there's no blood flow there. Yeah, so that's ventilation perfusion mismatch. So you should, if it is a pure atelectasis, the question and the answer is you should not be seeing the increased vascularity in that area. Now, coming to the question of the bronchograms, can we see static bronchograms in atelectasis? 100%. You can see static bronchograms. Can we see?
dynamic.
Exactly. Can you see the dynamic air bronchograms? Well, never say never in medicine. If it is a dynamic bronchogram, I would tend to think there is some infective process going on. I would err on that side rather than discounting it with the fact that, in some cases we can see dynamic air bronchogram in atelectasis as well. But purely from how the images are generated, can we see? Yes, we can see dynamic air bronchograms in atelectic areas as well. But if you see that, try to err on this side of infection rather than discounting it as a pure simple atelectasis.
Really, I found today area of middle lobe, right middle lobe, all middle lobe collapsed. يعني atelectated. All criteria there. But make an Doppler, it found the vascularity high. والسعر بي نيجاتيف. التوتال كاونت ماشي كلها مع فيرال. يعني
I mean, now we have to think about why that whole area has collapsed in the first place. I mean, something brewing there, leading to the atelectasis, blockage of the.
I will try to make an CT, even bronchoscope. I will see that's what was the reason.
Yeah.
Thank you.
Thank you.
Sorry again. If we have like a consolidated lung due infection, we said that we're gonna see the blood vessels there, or a positive by Doppler sign. But at the same time, for doing the thymus, because I want to get back to the slide where there was some query atelectatic apical atelectasis or versus a thymus. So again, in the thymus, when we ultrasound the thymus, there are vessels as well, and I can see in this that the bad wing sign is over there. So how can we
differentiate? Good question. Yeah. Excellent question. So when I was learning, I had a similar kind of a question. To answer that question, to a question is how the thymus is different. Say, okay, I will argue for you that this is a consolidation and this is not a thymus. Okay. So, and then I have to argue from the other end as well. This is a thymus. So how do I differentiate those? Okay, this is the consolidation because I can see, area which is not aerated, and it looks like, consolidated area as other lung, as it looks on the other part of the lung. Okay. All right. The argument for thymus. Well, can you see any broken or fractal sign here? Well, no. What do I see? A well-circumcised, encapsulated. There is a capsule around it. Okay. So if it is encapsulated and it is typically sitting on top of your heart, what do I think? Is it a consolidated area? No. Can I see a dynamic or static bronchograms, inflating or with the inspiration or expiration movement inside this encapsulated area? No. Okay. 3 for thymus, just 1 for consolidation. Now you can employ your Doppler interrogation on this area, because that's what you have learned. So am I going to see vessels? Yes, absolutely. We're going to see vessels in the thymus. Okay, 2 for your consolidation and 3 for the thymus. Am I going to see any sign of nice discrete pleural line with this thymus? Because remember, this is the first image, just perpendicular on top of it. I see a normal lung. Okay, I see a normal lung. I do not see any broken or disrupted or gross or diffuse pleural line. Okay, I angle the probe because it doesn't go with my chest X-ray. So then I found this one. Okay, so the lungs looks normal. Okay, there is no, this is encapsulated. There is no broken pleural line. There is no broken pleural line. Well aerated lung. So, and it is sitting on top of the heart. And for babies, unlike us, what sits on top of the heart, which is big and looks like a sales sign on a chest X-ray? It is thymus. And I think the 4 points for the thymus wins and not the consolidation.
Okay, thank
Make
you.
sense?
Yeah, yeah. Because I was a bit confused because I thought if we can see the bat wing sign, this goes more with the we cannot see the bat wing sign, so it's more of a thymus. But
Yeah.
still, now I get it this way.
Just to be aware, Marwa, thymus can vary in size. So you
Mhm.
might have babies who have very small thymic shadows, but if you have quite large thymic shadows, they can encapsulate the upper ribs. But also be aware that thymus can be left or right-sided. So
Yeah.
just it's really important that when you're looking at it, as Abhijita said, well demarcated lesion with a capsule with blood vessels within it above the level of the heart. That would fit more with a thymus than a kind of an atelectasis consolidation.
Yeah, that's correct. Yeah, thank you so much.
This is a great session. So more questions. Anybody else with questions? Okay.
All right.
I just wanted to thank Abhijit. Absolutely amazing session. I always learn from his sessions, and I think that's the reason why he's one of our showstoppers for this particular course. Absolutely no doubt about it. One of the
Alok, you're
things
being too modest.
No, not at all,
Too
not at
generous
all.
as well.
So as you can see, what we are doing with the flavor of the course at the moment is we've kind of moved from what we have as a kind of a didactic kind of an approach to more of what we call is an interactive interrogative approach. And now what we would be doing going forwards is we will be covering a lot of topics with more of an interrogative approach. So Thursday we have peer review. Please join us to present any cases, but I'll also be presenting cases. And in each peer review, what we do is we cover a particular pathology. So I'll be doing a lot of pneumothorax in the next peer review, where you'll get to present your cases first, but I will be presenting you with a lot of cases, histories, for you to make a diagnosis, very similar to how Abhijit has done today. And then on Sunday, we'll be covering RDS, each individual pathology with lung scoring, again, with a lot of a case-based approach. I'm really grateful to all of you for spending time with us today, and clearly if there's anything that we're missing out on, just private message me. God bless you, Abhijit. Thank you, everyone. Have a good weekend.
Thank you, Alok. And if I can put in a request here on the same platform, guys, I'll be very grateful if you can give feedback. What was good, what was bad, and how I in particular can improve, or what do you want me to, what do you have liked more about this session, where I should have stressed more. So it's just about learning and improving the upcoming sessions. So I'll be very grateful if you guys can give a feedback to Alok regarding last two sessions. Lovely.
Okay.
And I'll be very happy, Alok, to help you in any way possible in terms of, with these sessions. Yeah.
Thank you. God bless you. Thank you, everyone.
Thank you. Thank you.
Thanks very much. Thanks, everyone.
Thank you. Bye.
Thank you. Bye. Thank you.
Thank you.